Here I've just shown you a picture of emboli. You can see in this picture all these white dots that you're seeing, emboli in the vasculature. How do we know if this is an artery or this is a vein? Just to establish some basic differences, always the vein appears much darker than the artery. In the artery, you can see that central reflex streak which is more clear, and another important factor is veins are associated with more tortuosity. So normal AV ratio is 2:3. So veins are a little thicker and more tortuous. Again, in this picture, you can see very clearly the artery and vein are lying alongside each other. You can see that the veins are much darker and there is much more tortuosity in the veins. So this is the vasculature in this patient is normal. But what is abnormal here is the presence of emboli. So these emboli I would like to qualify a little more. So this emboli that you're seeing at the bifurcation of the artery, and this emboli you're seeing here along the vasculature. So these are the emboli along the vasculature. Again, arterial vasculature, but in a segmented pattern. This emboli here is an elongated emboli, and here you're seeing it near the optic disc. So each of this has a separate name. The three types of emboli can be, firstly you have what you call cholesterol emboli. First one is cholesterol emboli, also called Hollenhast plaque. So cholesterol emboli is typically by nature, it is refractile, minute dots that appear along the vasculature. The second type of embolus is fibrinoplatelet emboli, and that's what you're seeing in this picture. This is the fibrinoplatelet emboli, which is elongated. Classically, they are elongated, and generally they can even be present a little away from the optic disc. Like you're seeing in this picture, it's close to the optic disc, but this can also be present a little away. But the most important distinguishing feature is that it is an elongated plaque. Cholesterol emboli are yellowish. They are more yellowish, and this picture that you're seeing here is a cholesterol emboli at the bifurcation. The third type is called calcific emboli. Calcific emboli are present here. This is the calcific emboli, and this is present classically close to the disc. So when you see an embolus close to the disc, it's most likely a calcific emboli. And again, one more point to notice, these are whitish in color. So this whitish nature is because of the calcium. And so whenever we see a patient with an embolic etiology, we need to further understand whether it's a cholesterol, fibrinoplatelet or a calcific emboli, because the origin of these emboli could be different. And here what you're seeing here is multiple emboli are present, and this is because it appears refractile. It's probably a patient with a cholesterol emboli. So what are the risk factors? The systemic risk factors are older age group, hypertension, hyperlipidemia, diabetes, smoking and giant cell arteritis. Now these are the most important risk factors for a central retinal artery occlusion. Giant cell arteritis, like I mentioned, particularly in younger individuals. But how do we really classify? So it's easy to understand the etiology based on atherosclerosis, then emboli, the source. These are all the causes, or it could be inflammatory. It could be origin from the optic orbit itself. Alright. So these are the various types, and of course the miscellaneous type. So atherosclerosis, like I just mentioned, it could be due to diabetes mellitus, hypertension, hyperlipidemia and smoking and obesity. These are the commonest causes for atherosclerosis. Emboli is very important in the context of central retinal artery occlusion, because the origin of emboli can be from the carotid artery. So we call it carotid emboli, or it could be from even some aortic artery dissection, or it could be cardiac in origin, cardiac emboli. So when you say cardiac, it can arise from the valves. It can be vegetative matter such as following infective endocarditis, or it can also occur as a consequence of atrial myxomas, a tumor of the cardiac tissue, or it can also occur secondary to atrial fibrillation. So any of these conditions can predispose to an embolic etiology of arterial occlusion. So whenever we see a patient with likely central retinal artery occlusion, we have to obtain a cardiovascular surgeon's or a cardiologist's opinion. Inflammatory causes can be, again, it can be due to polyarteritis nodosa, systemic lupus erythematosus, sickle cell retinopathy, or it can be secondary to Wegener's granulomatosis, Behçet's disease, or sarcoidosis. All these are common causes of inflammatory etiology. Infectious etiology, we have to think of toxoplasmosis, mucormycosis. Mucormycosis is very significantly associated with arterial occlusions because it is an invasive fungus. It can cause occlusion. And another important cause of infection is syphilis, can also cause arterial occlusion. And orbital causes can be, ocular or orbital causes. Ocular or orbital causes, if it's an ocular cause, it can be migraine. And apart from that, you can also have it when patients with optic disc drusen. Optic disc drusen is a congenital anomaly classically defined as presence of calcific material within the layers of the optic disc during development itself. So when you see the patient, you will have a lumpy optic disc with anomalous retinal vasculature. So whenever we see that in a patient along with central retinal artery occlusion, you know that that is the etiology. So